There's been a lot of recent data that's been presented about both nintedanib and pirfenidone at two recent meetings. Firstly, the European Respiratory Society meeting that was held in September 2015 in Amsterdam, and then the subsequent meeting, the CHESS meeting, the American College of Chest Physicians meeting that was in Montreal in October 2015. And since both drugs have now been approved for IPF, specifically nintedanib and pirfenidone, there have been various looks at the very rich data sets to try and find out more about not only the natural history of the disease, but also about the drug activities. Some of the data that was presented firstly at the ERS about nintedanib looked at patients who had more mild disease versus those who had more moderate to severe disease. Specifically, as I recall best, they looked at the data set from the Impulsor studies and looked at those patients with FVCs who were greater than 90% versus those less than 90% to see if those patients behaved differently in response to nintedanib. And what they showed basically was that the patients who had the mildest disease, FVC greater than 90%, had a similar positive response to the drug as patients with more severe disease, those less than 90%. One of the messages from that particular analysis is that it's never too early to start nintedanib. Similar analyses have been done with pirfenidone as well, looking at early versus more later disease. And as I recall from the Capacity and Ascent studies, the groups were cut by an FVC of 80%. In other words, those greater than 80% versus those less than 80%, showing a similar effect. Patients with mild disease had a similar response and slowing of the rate of loss of lung function as those patients with more severe disease. There have also been some interesting looks at mortality related to the use of pirfenidone. As the viewers might recall from the New England Journal of Medicine article that was published in May of 2014, there was a look at mortality, specifically mortality at 52 weeks. And the way mortality was analyzed was all three pirfenidone studies together, Capacity 1, Capacity 2, and the Ascent study. And in total, there were about 1,247 patients that were looked at. If you look at the data cut at 52 weeks, there was a positive mortality benefit with a p-value that was statistically significant in favor of pirfenidone. What we looked at, and I was privileged to be the lead author on this, both at ERS and then subsequently at the ACCP, was having an additional look at mortality beyond 52 weeks using the combined data from all three studies. And what we showed, looking at mortality in a number of different ways, first of all, we looked at all-cause mortality, then we looked at IPF-related mortality, we looked at treatment-emergent mortality. I think it's important to understand what the difference is between those different analyses. When we look at mortality generally in the context of randomized controlled studies, we do an intent to treat analysis so that all patients, no matter how long they continued in the study, whether they were in the study for 1 week, 1 month, or for the duration of the study, are analyzed in their primary group. And that's the way we typically look at mortality from all these different studies. What treatment emergent is, and I think this is more clinically relevant because it is more applicable to what happens in the trenches, is what about those patients who were started on therapy and continued on therapy? How about just that patient subgroup, taking out patients who dropped out for whatever reason or stopped the study for reasons that are uncertain? And what treatment emergent mortality does, it tells you how patients will act or behave or how the drug might affect the disease course on those patients who you put on therapy and stay on therapy. And that's what we are obviously all more interested in. Basically what was shown, if you look at treatment emergent mortality, IPF, if you look at IPF deaths, if you look at all-cause mortality, first of all, statistically significant difference in favor of pirfenidone at 52 weeks, statistically significant mortality benefit in favor of pirfenidone at 72 weeks, and then as you get out to 120 weeks, there's a strong trend, if one can use that terminology, a p-value that's just above 0.05 in favor of pirfenidone once again. It's important also to note how these studies were done because the number of patients that we were following at 120 weeks was very small. The Ascent study was a 52-week study, and so we have data for patients at 52 weeks, but after that the patients either enrolled in open label therapy, but we stopped following them exactly at 52 weeks. The Capacity studies were 72-week studies, but patients were followed for as long as it took for the last patient enrolled to complete 72 weeks. And therefore, that's the reason we have data on some patients at 120 weeks, but the number of patients at 120 weeks is very small, single digits. And that's why the p-value is that there's a trend to significance at 120 weeks, but not exactly statistically significant. The bottom line from all these analyses, if you look at all-cause, treatment-emergent, IPF-related deaths, is that there is a consistent effect of pirfenidone on mortality at 52 weeks, 72 weeks, and then the trend, which I think is supports that the mortality benefit is sustainable over time, and the significance went away just by virtue of the numbers. This might be as good as we get with pirfenidone in terms of looking at mortality in a prospective, randomized fashion compared to a placebo group, because no one's going to do a study looking at mortality with a placebo control group beyond this period of time. So this is as good as it gets, and I think in summary the bottom line is that there is a very strong suggestion that pirfenidone has a mortality benefit that's sustained over time.